I have created an online module for the nursing staff because we have no current education on the detox process. So there is 6 objectives for you guys to hopefully meet after I'm done going through this presentation. First one will be that you can recognize alcoholism as an actual disease process and not just a chosen behavior. The second one, to be able to explain and understand the pathophysiology of alcoholism, and to know common signs and symptoms of withdrawal and inadequate withdrawal management signs and symptoms. Be able to state a CWIS score that would indicate your patient needs further medicating or further intervention, and know who to contact for your resources if you have questions or trouble managing these patients. So I will cover alcoholism as a disease, the pathophysiology, the signs and symptoms, the CWIS scale and our CWIS scale here at Sanford, the importance of treating withdrawal symptoms, medicating according to the protocol, nursing considerations, and resources. So we'll start with alcoholism as a disease. Alcoholism is constantly stimulating when there is alcohol present our neurotransmitter system in our brain. So that causes the increase of dopamine, which then gives us that feeling of pleasure or wanting more. So once it's constantly being stimulated, there's an increased effort to respond to the alcohol. So then it has to build a tolerance, and then it takes more and more and more to get that feeling of pleasure. So the dopamine receptors become less sensitive, and it takes more alcohol to, again, get that feeling of pleasure. And dopamine is what causes the pleasurable feeling, which then causes the craving or the addiction. Now I'll get into the pathophys of alcohol withdrawal. So like we just talked about, dopamine and causing that pleasurable feeling. In a normal person who's not drinking, dopamine binds to our GABA receptors. When there's alcohol, the alcohol blocks these receptors, and then there's a free amount of dopamine in the system, so then you have the feeling of pleasure. So when we withdraw or stop the alcohol, these GABA pathways open up, and that's when we see the hyperexcitability in the brain, like tremors, hallucinations, anxiety, seizures. So identifying your signs and symptoms, the most common ones we see are the tremors, the agitation, anxiety, nausea, vomiting. But included with that is when our autonomic nervous system starts to overact, then we get the increased vital signs like the tachycardia, the tachypnea, the hypertension, increased body temperature, those kinds of things. Insomnia and nightmares are also have to do with the autonomic nervous system being overactivated. So 10% of our patients have hallucinations. Probably seems like more than that at times. But 2 to 5% of alcoholic patients also experience with actual withdrawal seizures. Different things to make sure we do when patients are having these signs and symptoms to keep us safe and the patient safe is private room, which I know we're doing as much as we can right now to do that. Utilizing sitters as needed for aggressive or flight risk patients. Make sure we're wearing our locator badges, and make sure that we can access that panic button if we're put in a difficult situation. And make sure before we're going in the rooms we're taking off our lanyards, our jewelry, stethoscope, and things that could be harm for us if the patient got aggressive. If you have long hair, they recommend tying that back as well. So now the CWIS scale stands for Clinical Institute Withdrawal Assessment for Alcohol. It is a symptom-triggered therapy, meaning that we treat the patient based off of their symptoms, not like a scheduled medication, Ativan 4 times a day to treat withdrawal. It is the most commonly used evidence-based tool for helping our patients withdraw safely. And we can do it and assess, and you guys know this, within 2 to 5 minutes it usually takes, and we repeat it per the parameters of the protocol of our hospital. So our CWA tool, which you guys probably are familiar with, we just included a picture here with the docs and flow sheets and where to find that and how to score it. This includes the vital signs part and then the CWA question part. This is what it looks like on the Cardex, and this gives just a better view of the actual details of scoring it, like what kind of instruments you would use for scoring a blood pressure that's higher or lower, temperature, and your heart rate. It also tells you at what point you should notify your provider. So the importance of treating the withdrawal symptoms, and I have a little bit more information here on that. Find the rate sheet. So, alcohol, as we know, is hard on our cardiovascular system. It increases our blood pressure and stimulates our autonomic nervous system. The chemicals in the alcohol are toxic to our myocardium, which then can lead to cardiomyopathy with alcoholism. Vitamin deficiency, which we commonly see in alcoholics, is because the small intestine does not absorb sufficient amounts of vitamins. The importance there is replacing things like the thiamine, the folic acid, the vitamin B6. This is why they get the banana bags before they come up. This can lead to, if not treated, Wernicke's encephalopathy, which causes the lack of thiamine doesn't meet our cerebral demands in our brain, so this causes confusion, altered mental status, nerve cell degeneration, and can lead to worsening signs and symptoms of confusion, things like that. If it completely goes untreated, it can lead to the Korsakoff psychosis, which then is an actual permanent condition of psychosis, memory loss. Seizures again occur in 2 to 5% of our patients, and usually within the first 48 hours. Withdrawal seizures are not going to respond to your dilantins, things like that, because the cause of the seizure, we actually need to treat the underlying cause of the seizure, which is the withdrawal or the symptoms. So medicating according to our SIWA protocol. Making sure that you notify your physician if you're approaching that 30 milligram and 24-hour mark. The SIWA orders are only good for 96 hours, so if you have a patient who is admitted and they don't start withdrawing for 3 to 4 days, you're almost approaching that 96-hour mark, and we also almost have to have it renewed. And then just make sure you're administering the medications per the parameters of the SIWA orders. There are concerns about over-medicating. Signs and symptoms of this may be respiratory depression, decreased level of consciousness, response only to painful stimuli, or requires supplemental oxygen to maintain their oxygen saturation. Here's a picture of what the SIWA scale looks like from the MAR, and just remember that they both look very similar, but one is for oral dosing and then one is for IV dosing. It is important with these patients to use simple factual statements. They have the right to know their information, so doing bedside report is still a priority. We want to be there at the bedside so they know what's going on with their plan. Just caution when discussing their discharge plan, because as we know, they can get agitated when they find out they're going to the state hospital and they hadn't heard that, or that was the first they had heard of that, so that stuff I would not say at the bedside. Remember to be supportive and not let your feelings or judgments get in the way of caring for these patients. And your resources. It is important to know if you have questions or having trouble with a difficult patient who to contact. So I would say first try your charge nurse on your floor. The resource team has a rescue nurse. They should be knowledgeable in this as well. Any of us on the 6th South floor or the charge nurses. House administrator, your rapid response nurse, patient flow coordinators, because they are also house administrators. Psych resident, the psych attending or the on-call psych physician, and then you have your chemical dependency counselors and your social workers that are here to support you too. Just one thing to remember is that when we have a patient who has altered level of consciousness and they may not be alert and oriented, that we need to then look into the substitute consent decision maker at that point. But that I will not go into at this time because it gets pretty in-depth. So there will be a link on here to the policies if you guys want to look at them that way. So after reviewing this course, you should now be able to recognize alcoholism as a disease, not a chosen behavior, explain the pathophysiology of the withdrawal, identify common signs and symptoms of alcohol withdrawal, define the risks of not medicating appropriately, stating a SIWA score that would indicate your patient needs further medicating or calling the physician, and indicate who to contact as a resource if you have any further questions. That's all. guys have any questions?
Yeah. We used to have to give half the CWAS, or half the Ativan to a patient that we gave them a day before. Is that still something that we have to do?
They're saying that there's no evidence to back that up anymore because of the concerns of over-medicating, and then patients are ending up in the ICU or things like that because their respiratory status, they couldn't keep up the drive from the over-medicating.
Sounds good.
Anything else? No? Okay.
Good job, Courtney.